Okay. Hey. Hi, everyone. Anyang, just to check, do we have everybody on the team, everybody coming in right now?
Yeah, let's have a little more minute for people to join.
Of course. For those of you that are joining now, we're waiting for people to arrive, so we'll start in a couple of minutes.
Hey, Dean.
Hi, how are you?
Good.
Wayne, hi.
It's like SOBP never ended.
It's going.
It's the after party. Yes, so I think we have everybody in the line right now. Okay. Good morning, everybody, or evening, because I know there are lots of people joining across the US and from abroad. And welcome to today's webinar. My name is Min Soo Lee. I'm the Director of Business Development at Soundable Health, and I'm delighted to be a moderator for this session. Today, as you all know, we'll be discussing the key takeaways from 2025 Society of Benign Prostate Disease, SOBPD, as we will call it from now on, annual meeting, which took place February 7 to 8 in Orlando, so it hasn't been long, so it's very fresh on all of our minds. This session is a great opportunity to stay informed about the latest advancements in benign prostate disease management and gain valuable insights from expert perspectives. As we go along, please feel free to share any questions or comments on the chat, and we'll do our best to address as we discuss. Now, without further ado, I am honored to introduce our speakers, the three we have today. Dr. Bilal Chughtai will be the keynote speaker, and then we'll be leading the discussion today with Dr. Wayne and Dr. Kuang. Yes. And we have Dr. Altman for a discussion, who has just joined us from right out of surgery. So yes, that's how we go. Yes. I would also like to do an introduction for each of our speakers today. Dr. Bilal Chughtai, Chief of Urology at Plainview Hospital, completed his medical degree at Stony Brook University, followed by residency in urologic surgery at Albany Medical Center. He completed his fellowship in male voiding dysfunction, neurourology, female pelvic medicine, reconstructive surgery at Memorial Sloan Kettering Cancer Center, and New York Presbyterian Hospital, Weill Cornell Medical College in New York City. Dr. Chughtai specializes in female pelvic medicine and reconstructive surgery and male voiding dysfunction. He maintains a longitudinal interest in these highly prevalent and debilitating conditions and has focused both his clinical research and teaching activities on these areas. Yes, Dr. Wayne Kuang is a renowned urologist and the visionary founder of Men vs. Prostate, a groundbreaking grassroots movement dedicated to revolutionizing BPH care. With a passion for preserving bladder health, Dr. Kuang is committed to ending the over-medication of BPH patients and preventing the progression of late-stage disease. A graduate of MIT and Stanford University, Dr. Kuang completed his urology residency and fellowship training at the Cleveland Clinic in 2006. After serving as a faculty member at the University of New Mexico and a partner in a large urology group, he cares for his patients at his solo practice MD for men, specializing in men's wellness since 2014. Yes. And lastly, we have Dr. Dean Altman, who has completed his medical degree followed by residency in urologic surgery at the University of Toronto. He became a fellow of the Royal College of Physicians and Surgeons of Canada in 2011. Dr. Altman completed a 2-year fellowship in voiding dysfunction, urology, female urology, and pelvic reconstruction at Memorial Sloan Kettering Cancer Center and New York Presbyterian Hospital, Weill College of Medical College in New York City. Dr. Altman has worked in the areas of men's health and survivorship and is currently the medical director of the Prostate Cancer Rehabilitation Clinic at Princess Margaret Hospital Cancer Center. So, and also I would like to introduce, before we dive in about Soundable Health, the company behind today's webinar and where I am as a part of. At Soundable Health, we are dedicated to advancing digital health solutions for bladder and prostate cancer care through AI-driven technology. One of our flagship innovations, proudP, is the simplest way to perform uroflowmetry in your office. Managing a busy practice requires solutions that enhance efficiency and patient care, and proudP, an AI-powered uroflowmetry replacement, delivers clinical-grade accuracy while streaming clinic operations. Now, I would like to get started with the main discussion of the today. Dr. Chughtai and the panelists will walk through the key findings from the conference, and then we'll start off in a discussion manner, and then we'll continue asking questions so that we can cover an engaging discussion on SOBPD that happened last week. Okay, we encourage again for you to submit your questions through Q&A feature at any time during the session, and we will reserve time towards the end to address as many of them as possible. So over to you, Dr. Chughtai.
All right, well, these are my disclosures. I guess we can move to next slide. All right. So I think when we talk about the SOBPD meeting, I would say, and Dean and Wayne, feel free to add. I would say it was an exciting meeting. I think we saw a lot of innovation when it comes to new surgical therapies. I think there were a lot of excellent presentations. I think one of the first that I thought would be interesting to highlight was talking about the BPH guidelines. And I think we got a really nice insight onto how the guidelines were developed and how the first guidelines were developed. I think it was interesting to learn how there was a lack of randomized controlled trials. And essentially before 1994, there was not an established way of how to treat these patients. I think we can go to the next slide. And this is a slide from Dr. McVeary. So here we saw that there was between 1994 to 2023, I think initially we saw that there was a very stepwise approach to BPH. So patients who were in the mild category would be sort of watchful waiting, and then they would move on to potentially medical therapy if their symptoms worsened. And only at medical therapy failure was the discussion of the change to some type of surgical intervention. Now I think there's a much more patient-centric view around it. Dean, what was your take on that?
Yeah, I mean, I think as evidence has increased over time, we have a better understanding of both the levels of evidence, and the grade of recommendation, and also sort of being able to balance what is coming out onto the market, and then being able to evaluate and assess best practices based upon the literature that's provided, right? So guidelines are always there to help provide some guardrails. They're not mandates, but certainly as more products have come onto the market and our better understanding of how to evaluate patients has become a bit more mature, the guidelines have also matured along with that.
Wayne, what was your take on that?
I thought it was fantastic to have the insights, not only on the guidelines, but like on your work, Bilal, with clinical trials. The amount of effort and work and dedication by the academic brigade is out of this world. It's fantastic. Thank you so much for all you guys do. I think what I'm realizing, we're now beginning to reflect what the modern man wants, right? Not just to live longer, but better with their data. Remote diagnostics, our phones, our watches, right? We're now allowing and empowering men to have their own data to share in the decision-making with the urologist, with the healthcare system, with the bladder. And I think that's fantastic. We're seeing that evolution forward. And I think it comes from the biggest takeaway I had from this whole thing is energy. Dean, having that drink with you, that beverage of choice, you said something which was really spot on, which is so unique to SOBPT and BPH, BPO around the world. There's something about the prostate and the bladder that makes people inclusive and wanting to share and being open to other ideas. I'm just some random guy from the desert of New Mexico, and both of you guys have welcomed me, man versus prostate, bladder preservation, with open arms, because it's just another idea, and how do we incorporate it? And I think that's a real credit to the leadership of the academic brigade set forth in the guidelines, and I'm excited to see where we go from here.
I think one area that became interesting from Dr. McVeary's presentation here is his the change in the PAE recommendation. Now we saw a change where it was first under clinical trial only to now it is a reasonable option, for patients, the way we would recommend other BPH therapies. Wayne, Dean, what did you think about that? How do you guys utilize PAEs in your practice?
I think PA is sort of twofold. Number one is it's being done, right? And it's being done by interventional radiologists. And so we as urologists need to either push it away or understand it and embrace it and get a little bit of sense of control and have it in our guidelines so that we know who are the best patients. Also, to be fair, the data has started to mature, right? There are more studies with a little bit more evidence that support the use of PAE. And so I think adding them to the guidelines was a little bit of a reflection of maturing data coming out, as well as accepting real world PAE. In my practice, we do have PAE. The way that we've really streamlined it, and I think this is the appropriate way, is that all referrals have to go to a urologist first. Then we do a general BPH workup and we determine whether it is appropriate to go to the interventional radiologist. So we remain the gatekeepers. And I think this is really important because an interventional radiologist doesn't know necessarily the difference between OAB and BPH. They don't have instruments like uroflowmetry. And so that's how we've sort of been able to keep some hold on it and work as a partnership. And we also do tend to do larger size prostates. And I think there was some evidence presented at the SOBPD showing that it is certainly more effective in those larger glands.
Dr. Altman, you just mentioned that we are serving as a gatekeeper. That's the role that we play. And you talked about how it's very important to differentiate what types of OAB between BPH and many different conditions that are out there. What are some of the procedures that you kind of implement in your own practice to make sure that you become that great gatekeeper and is able to actually give a good diagnostic result? It'd be great if you could share some what you do in your daily practices.
Yeah, I mean, when patients come in, we have to. The history is the most important. Honestly, it remains the cornerstone. Because if someone says I have frequency every hour, urgency, that is much more OAB. If they have incomplete bladder emptying, it's a little bit of a nuance. Are they having frequency because they're not emptying, or is there urgency associated with it? So we do give them validated questionnaires like the IPSS. I do like to do uroflowmetry on essentially every male patient for sure that comes through the practice with a post-void residual ultrasound. And for those men who are considering doing something, we also get volumetric assessment. I really do tend to get a lot of prostate ultrasounds as well. So good history, physical exam, which is really flow, PVR, truss. So those sort of extensions of my physical. And then we make determinations as to where to go.
How about you,
I
Dr.
think,
Chughtai? How do you practice?
and so I was going to add one thing. I think, Dean, I think you're really hitting that on the head, which is that when you talk about PAE versus every other BPH therapy, I'm pretty certain that, and Wayne, I'd love to get your insight on this as well. Almost all my patients are getting cystoscopies, transrectal ultrasounds, they're getting uroflowmetry. So obviously, when we're incorporating PAE as a part of the treatment paradigm, those patients should undergo the same workup.
Great. Yeah.
Yeah, absolutely, Bilal. And I think I've just echoed both of you that it needs to be a partnership. Let's learn from history. Defender Ruxtalis actually stopped me at the end and just said, hey, we need to start thinking about past history and what happened with focal therapy of the kidney and the role of urologist and the role of interventional radiology. We will go farther if we are together with interventional radiology and as urologists. And I think we can do that. Here in my current healthcare system, which is not is a low income healthcare system, we don't have as many resources with PA, but as always, as all defenders know, your best deobstructions, whether it's PAE, et cetera, or in combination or staged, are the ones you do best for the right patient at the right time and are the best fit for all four at the table of shared decision-making, right? The patient, the bladder, urologist, and the healthcare system. So we all must find that sweet blend between all four of those entities, and we can do it as long as we continue that dialogue that Dean talked about. In regards to an evaluation, Minsu, I think it's really
Yeah.
important because I know there's a lot of primary care docs out there as well. Meeting the men where they are with the right dialogue, and we synergize that with data. And I think that, as Dean said, right, a good history. And that's the patient talking. But remember, behind that, there's a bladder talking. And so we have to be careful that we're listening carefully. That urgency, frequency, getting up in the middle of the night is the bladder talking. And we have to be careful because the patient can over talk or speak over the bladder and not allow the bladder to be represented. Its needs and preferences of the bladder need to be incorporated and integrated into decision making. So I think that's just important. I think we do that with data. And remember, there's so many, if you're a primary care doc, remember, hey, there's only 2 organs you can't transplant, right? The brain and the bladder. We got to take care of that, Mr. Smith. So these are reasons why we need data. Well, what's easy data that we can obtain in primary care? Now with remote diagnostics, we can get that uroflow. And if a guy has an IPSS 8 and above, for example, with a Q max that's lower, some people say less than 15, less than 10. Hey, maybe that's a right person that needs to go see Dean or Bilal at their BPH, BPO battle stations where they can take care of not only the prostate, but also the bladder.
Yeah. I mean, I'm glad you mentioned all of you talked about the historical data points, because that's one of the areas that proudP is really, really doing well. And we're very much interested in diving forward. I have a big, all of you 3 in commonality mentioned the word history. So what will be like very like top of your mind, a typical way that you gather these history points? Like, for how long is it been, how long do you ask your patients to keep a track record, or at least keep in mind of their symptoms? What would the months or like weeks be?
I think when we look at, I think all 3 of us here probably use IPSS, and we use that sort of as our starting point. A lot of times I would use that survey instrument as the starting point of talking about history. But I think also with the history, there's some degree of subjectivity to it. And that's where I think Wayne has a good point in terms of, like, there's a bladder behind all this, and the symptoms can be subject to interpretation as well. And I think it's important for us as physicians to help uncover that and really understand, what their primary complaint is and what the goals of care are, and what the next steps are going to be for the patient.
Okay, great. Yes. I think this conversation started with the guidelines. I think we could also talk about a couple of treatments that were mentioned in SOBPD. So I think if you have, do you have any more, would you have any more discussions on the guidelines aspect?
So I think, Minsu, before we go on to the treatments, there was actually another wonderful presentation done by Doreen Chung on the OAB guidelines. And I think one thing that was really notable here, and I think in our practices, originally there was a stepwise progression for overactive bladder, the way it was previously for BPH. And now, as opposed to being a stepwise fashion, you're really making shared decision making to move patients to the appropriate therapy. Because again, we're learning medications are not completely benign. They can have some long-term and irreversible sequelae. And I'd love to get Dean and Wayne's input on sort of how does this change your practice in terms of the fact that you're getting away from step therapy?
Yeah, I think there's a lot of parallels between BPH and OAB management. As we've had new advances in BPH, we have the minimally invasive treatments, MISTs, and a lot of men are opting to bypass medical therapy to go directly to a MIST, for example. And on the OAB side, there is a lot of morbidity associated with the side effects from the medications, dry mouth, constipation, et cetera. And there's this perception now that I think Botox and neuromodulation are kind of considered minimally invasive. They're really not maximally invasive. And so why wouldn't we give our patients the opportunity to jump ahead to something that is really much more of a long-term treatment, a long-term cure in many cases, as opposed to just treating the symptoms with medication? So I think this is a big step forward. I really like it. And of course, we have a lot of men, 50% of men have an overlap of OAB and BPH. And so these OAB guidelines are very much applicable to our male patients who have mixed storage and voiding symptoms.
I mean, I would also add the fact that I think when you think about from a practice standpoint, right? And you think about step therapy. So let's say a patient comes to you, right? Very interested in Botox or very interested in sacral modulation. Now, all of a sudden, as opposed to focusing on that therapy, you're really focusing on following a guideline and pushing that patient back, being like, hey, look, let's try this medicine that could potentially cause, has a sequelae in terms of like dementia, cognitive decline, right? Constipation. So I think with a new guideline, it really does allow us to tailor that therapy. I mean, you're still telling the patient about other treatment options, but to move them to the therapy that sings to them, I think is a wonderful step forward.
Love how you say sings to them, right? How does it resonate with them? How do we get the right data to resonate with them, whether it's a Qmax, whether it's urodynamics, enhanced or advanced? I think it's awesome that now we're saying, look, let's tailor it to the man. Let's meet them where they are. And I think that's really special. And I think especially other highlights from the meeting was Joel Funk talking about intraoperative Botox, right? Chemo denervation. I think, yeah, that bladder conversation is now starting to come in. And how do we find that sweet spot? How do we mix and match multimodality staging? And I think that's really exciting for all of us as we see that. And I'm really glad that now the OAB guidelines has that subset and it says something about BPH, BPO. And I think that's really valuable.
Great.
And
All right. So I think, I'm sorry, Minsu, go ahead.
no, go ahead. No,
Yeah.
after you.
I was going to say, I think Wayne alluded to our next thing we should talk about, which is, I think there was, we'll go to the next slide.
Yeah.
And I think this is also a really neat slide. I think this is by Dr. Glazier, where, I mean, he really looked at, looking at the reduced data, and we were looking at the correlation between prostate volume and IPSS. I think looking at this diagram, we can also, look at one of those plots and say, what do we all see? But I think clearly there's no pattern. And I think it's very cool to understand that, men with small prostates can have significant symptoms. Men with large prostates can have very little symptoms. And again, it goes back to the idea of like the patient-centric approach. Dean, Wayne, what did you guys think of this?
I love this picture. I almost want to frame it as a piece of art on my wall. We were always told like prostate size does not equal symptomatology, right? The bigger the prostate doesn't mean they have worse symptoms. And I think this picture really distills that idea. And it also speaks to the fact that you do need to have other points of data. You can't just have a simple prostate volume and IPSS because they may be very discordant and you don't know what's going on. If someone's got a very high IPSS and a small prostate, the possibilities of the differential diagnosis are really there. So adding in things like urine flowmetry, multiple readings with urine flowmetry, like with proudP, like all of those things are going to give you more data points. So you're going to be able to say, is their IPSS really high because they have OAB and the stored symptoms are driving it? Or in fact, do they have a small but tight and obstructing prostate with a very diminished Qmax? And maybe they're even starting to have detrusor underactivity and a weak bladder as the stages progress. And I think Wayne can really speak to those stages and data collection and IPSS not being the only thing.
Absolutely. So I think it's really neat to see that from the standpoint of like, size matters in some things, but when it comes to prostate size, I mean, it doesn't really correlate with the symptoms. Wayne, you were going to say something?
No, I loved this slide. In fact, I wanted to kind of Google Lens it and try and find where that was from. But I think it really highlights that we're seeing this evolution forward. And I talked to you, Dean, about it, which is now multifactorial. Is there a high bladder neck? Is the prostatic urethral angle more than 35 degrees? How much anterior tissue is dropping down, right? We've learned that from the anterior box technique from UroLift, the 12 o'clock anterior commissurotomy with Optilume, and the 12 o'clock tined from iTind, right? We're starting to now customize to the anatomy. And I think that's going to be really important. And yes, I think we're going to start seeing that evolution. There's such a emphasis placed on prostate size, but as we all know, prostate size, prostate shape, and bladder function together, how do we find that magical sweet spot to deliver the best customized, personalized care to meet the needs of the patient and the bladder?
Great. All right, so I think we'll head to the next slide here. All right, and this is why I think Dean, you did the perfect lead-in of Wayne's slide on bladder health. Wayne, why don't you just run us through the slide?
Yeah, so I think what we wanted to do from a community basis, so I'm reaching out right now to all those community urologists, those primary care docs. The dialogue is really important. How do we ignite it? You guys are overworked, understaffed, seeing way too many people. And really, we needed a way to communicate clearly to patients that what is at stake. And BPH is really about bladder health. The bladder is not transplantable. Let's take care of it. And for your primary care docs, remember, there's a lot of great analogies with the heart muscle because everyone knows about a heart attack and heart failure. And as we see on this slide, we came up with a communication tool. This is very important. It's just a communication tool. Quick shout out to Alexander Glazer from the last slide. He has done valuable work on a new validated questionnaire called the Learn. There's other ones out there.
Yeah.
Oh, you are? Okay, perfect. Yeah. I just want to bring that up, and I think it's valuable to note. But yeah, so there's 5 stages of the bladder health. The first one, remember, the prostate is not a walnut. Leave that walnut alone, okay? It's about the size of a golf ball and the shape of a mini donut, right? So as the prostate gets bigger, the donut hole gets tighter. Flow will slow down. That's stage 1. Stage 2, that bladder muscle is working harder, quivering, struggling, causing urgency, frequency, getting up in the middle of the night. Stage 2, overactive bladder. Stage 3, if you don't take care of it, the bladder will act out like a rebellious child. Squeeze without your permission, causing leakage of urine down the leg. Stage 3. Stage 4, just like the heart can have a heart attack, the bladder can suddenly stop working and they show up in the emergency room needing a catheter. In stage 5, just like the heart can go into heart failure, the bladder can go into bladder failure, causing a lifetime of catheters. And so take what you need to from that concept, right? It's not transplantable, analogy to a heart, but realize from a patient perspective, these are the fears that they have. And now we're communicating that there's a lot at stake. And that's why we need data. Good data drives good decision-making. And that's why we're all here talking about that, because data and dialogue can help find the right de-obstruction when warranted.
And I think, Wayne, I think you said this really well in terms of the fact that, one, it's a great communication tool. I think it's great for hypothesis-driven discussions, right? But we need data on trying to understand what are the evolutions. Do stages overlap? Do stages skip? And we need to figure out how this also plays a role in the timing of procedures. So I think it sparked an incredible discussion at the meeting. So it was amazing for you to share that with all of us. All right. I think in the interest of time, I think we're going to go to the next slide. All right. So I thought, Dean, you and I talked about this at the meeting. I thought this is fascinating to the additional tool. And I think what we're learning is that there are other things that, the IPSS is a great starting point, right? But there's additional data points that maybe we're not covering as well. So, how do you guys see this changing your practice from the survey standpoint?
The IPSS is the best of what we have, and it's a validated questionnaire that's been around a long time, but we have such a greater understanding of what lower urinary tract symptoms are. And A, they're not always caused by the prostate. B, we don't capture everything with the IPSS. Certainly, there's a lot of stored symptoms that we're kind of missing. And there's an opportunity to enhance it, to make it a little bit better, to ask about incontinence, incomplete emptying, pain. And so, as Wayne was saying, there's more to it than just the prostate. We have to think about the bladder. We have to think about how everything is functioning together. So a newer, updated questionnaire, I think, would be really welcome. And there's an opportunity for us to study it, to validate it, and to start giving it to patients so that we have a more holistic view of the lower urinary tract.
I would also say, like, one thing I was also surprised to learn was that I think Dr. Funk had brought this up in terms of like the rates of incontinence when you ask men prior to procedures, right? It's a lot higher. I mean, like, I think in the meeting we were discussing rates about 30 to 40%. And when we talk about surveys like IPSS, it doesn't capture that. So in terms of like picking up on incontinence, we ask all these questions post-procedure because they're theoretical risks. But I think being able to capture this pre-operatively is also incredibly helpful.
So if all three of you, like when you're conducting the IPSS, are there any questions that you ask your patients, a little bit of your own know-how to actually kind of complement what IPSS is missing so that you get a bit more holistic picture about different symptoms and the frequency of it?
Well, a lot of people sort of separate out the subscore of the IPSS into the storage and voiding subtypes, and I think that's really helpful. you can see what are the predominant symptoms. One thing that I'm always looking out for is looking at the storage symptoms, so the urgency, frequency, and nocturia. And if they are really high, either A, they have OAB, we've not got the right diagnosis. B, they've got two concurrent diagnoses, BPH, OAB. And also you have to be able to counsel them, because storage LUTs, OAB symptoms, don't necessarily resolve entirely in everyone after BPO surgery. And I'll add that nocturia is really, I call it a fickle foe. Wayne, you can use that. Nocturia is tough. Nocturia is so tough because it's so many reasons that you could have nocturia, right? Nighttime urgency, nocturnal polyuria, medications, incomplete bladder emptying. So if they score really high on the nocturia question, I always look at that. I try and dig a little deeper as to why, and I counsel them. Because if the number one reason that they're getting BPO, BPH surgery is their nocturia, they may be very unhappy campers because it may not improve very much. Right, Wayne?
Absolutely. I think that we all know it's the sheer exhaustion of getting up multiple times at night. And men are not being able to be the best version of themselves as fathers, as sons, as coworkers, as bosses. And I think, yeah, nocturia is a fickle foe. That's a great one. I just want to bring up, I think the Learn 10 is something that everyone needs to start at least looking at and see if it's a good fit, because one size does not fit all urologists. Just so you know, right now on LinkedIn, there's a poll going around about what questionnaire people are using. 90% around the globe on the LinkedIn tribe are using IPSS. 10% is going to be the ICIQ male LUTs. And I think that Learn currently has no votes. So vote for that if you're using it, because I want people to be aware of it. A lot of work, hard effort, expertise and experience has gone into the Learn 10. So I think it's exciting. Yes, about incontinence, I think it needs to be added, because from a patient-facing perspective, that is terrible. In New Mexico, we have a term for that, which is El Viejo Meow. It's that guy, we kind of just say it's the guy sitting on the porch who's just sitting there leaking on himself. There's a whole name, and these guys just have to live with it, but they don't, and we all know that. Ms. Minta, you asked a great question. I guess I wasn't really going to bring it up, but since it was brought up, the way I bring it up for right now on LinkedIn, we're beta testing the IBPSS, and it's what Dean just talked about. You guys probably can't see it, but once again, the voiding symptoms, stage 1, storage symptoms, stage 2, then stage 3 is urge incontinence, stage 4 is retention. We're helping to see whether or not we can immediately bring in the conversation about the bladder by putting it in the title, the IBPSS, and whether or not they can start self-diagnosing. Wow, yeah, this is more serious than I thought, right? And they can, the patient can understand there's a progressive nature to this, as well as there's a question about sexual health. In our conversations with folks in Europe as well as South America, the impact on sexual performance can be a strong motivator for men to engage deeply with their data, whether it's Qmax, urodynamics, so forth, to find the right solution for them. So yeah, I think it's a great time for us to understand these validated questionnaires, which have really can enhance the experience for everyone, patient, provider, healthcare system.
Yeah, and I think bottom line, if we don't ask, we won't know. And if we don't know, we can't figure out how we impact these conditions. So I think, I mean, looking at this, I mean, bottom line, if we don't ask about pre-incontinence, we don't know what it means for post-op outcomes and who does well with which therapy. Same with post-void dribble, and same with pain. I think a lot of times we separate pain out and we're thinking more urinary tract infection, pelvic floor dysfunction, but there's plenty of men who present with BPH and bladder outlet obstruction that can have straining, and they can have pelvic pain with this as well. So I think it's important for us to assess these conditions.
Okay, great. I would like to, for the sake of time, to move on to the next slide, and then we can discuss more about the treatment side that was discussed. Yes.
Yeah, so this is a great summary slide with Dr. Ricky, and where he talked about the hypoxia and the role of BPH. I thought it was fascinating work, especially how the interactions between the different cells and how this could be a potential mechanism for us to understand, potential medical impact, as well as those who can go on to have fibrosis and further changes in the prostate. Dean, Wayne, your thoughts?
There's so much that we still don't know about BPH. You know, it's almost like Neanderthals. We're trying to cook and steam and pin and you know measure flow, and we really don't get into the pathogenesis of it. We have great professors like Bill Rickey who are looking into it, who understand that hypoxia, that other cells play an important role in stromal and epithelial proliferation. But we're still a long way from having a pill that prevents BPH, right? And so I think this is really the future. It's really exciting that basic scientists, PhDs, are looking at the development of BPH, and ultimately we may get to a point where we can have some directed therapies.
Yeah. And even one step further, I mean, like, even when we're talking about our tissue altering procedures, right, versus cavitating procedures, this could be the beginning of the discussion of sort of who does well with which therapy and how to select them better.
True.
Exactly. And I think for me, the takeaway is actually the role of estrogens. For me, that's fascinating, right? Selective estrogen receptor modulators, whereas enclomiphene, so forth, right? How does that all play in the milieu, testosterone, estrogen balance with dihydrotestosterone? I think that's going to be exciting as we progress and understand these molecular basis for pathogenesis of BPH, BPO.
Okay, great.
All right. So I think now we're moving on to more of the surgical discussions, and this is Dr. Grant brought up his technique and how he uses green light. I thought what was neat here is that you know, we've seen the classic teaching about the role of HOLEP and what's unique about that technology, but I think we're seeing more and more, and I think during this meeting it really was highlighted that enucleation is enucleation is enucleation. And if you're really good with whatever energy, I mean, it really does allow you to maximize tissue removal. Dean, what did you think?
I agree. I mean, listen, I think whether you're going to eat something with a fork or a spoon or a spork, I mean, it's all going to get done the same. So I think everybody has really accepted that enucleation is one of a number of really good techniques. Each of the energy sources has its advantages and disadvantages. But I think ultimately enucleation is a really good option in properly selected patients.
Yeah.
Yeah, I agree. And I think you hit it on the head, which is, I think, Thomas Herman, right? Enucleation is enucleation, which is enucleation. And I think we're now seeing worldwide, people are having to find the right fit. Dean, you commented on LinkedIn about Juan Justo Quintas' paper they just published, right, from the ROC clinic in Spain, looking at enucleation versus aquablation, right? And now we're seeing that head-to-head, what's the right fit? How much tissue do we need to remove? And we're finding those answers now. And this is an exciting time for the category of invasive surgical therapies, which is what's the most you can do or your maximal approach.
Agreed. Right. All right, and I think this is another great presentation by Dr. Mandeville talking about the role of HOLEP in prostate cancer patients, because I think in some ways, right, this meeting is focused on we're the inside of the prostate, right, and then we've got the cancer guys who are the outer, like the peripheral zone of the prostate, and these diseases tend to coexist, and there's lots of men on active surveillance. I think when it comes to these men, I think we're understanding better how these therapies fit in. Dean, how do you counsel these patients with prostate cancer and BPH?
Well, I think the fear that doing some BPH procedure is going to negatively impact prostate cancer from a biological standpoint or a future treatment standpoint, I think is generally allayed. I don't think that's a major concern anymore. And certainly we don't want to have men who are suffering from BPH LUTs just because they have some form of prostate cancer, especially if they're on active surveillance, right? So I think most of the time we're going to see men who are on active surveillance. We should offer them something for their BPH LUTs. And then understanding the timing is really important with respect to treatment. And then vice versa. I mean, if we have incidental findings of prostate cancer after doing BPH surgery, what does that mean? And generally, the takeaway is nothing. These guys are totally fine to be monitored or have future radical treatment if needed.
Well, I think one other thing that was interesting from this talk was that how do we use PSA as a marker of our success for procedures? Wayne, Dean, do you guys get post-operative PSAs on procedures that you do and say, hey, we saw a 50% improvement in your PSA, therefore, or greater, right, or less, and say, hey, we could have taken more or we didn't take enough?
Yeah, I think that's a great question. As far as I get PSAs after procedures just to see a sense of one, not only how much tissue was removed, but also a new baseline for prostate cancer screening. And I think that for me, that helps to know where they are. I expect it to go up slightly due to inflammation and healing. So that's how I use my PSA post-operatively.
Yeah. PSA is helpful in the post-op, again, to understand what you've done and then moving forward for surveillance. With enucleation, there's a generally accepted cutoff that you're going to expect X% of reduction in PSA, and anything more than, what did Jessica say? It was like a few percentage increase, then that would be cause for concern as opposed to it's being benign.
Agreed. And I would say, like, I agree. I think in some ways, us removing the benign component or working on the benign component does give you a new baseline for the PSA. And it's an interesting way of incorporating it into our practices. Dean, Wayne, how much after a procedure would you consider that you got the like the new nadir or the new baseline for their PSAs? Do you guys use a cutoff of 3 months, 6 months? When do you typically say that's the nadir?
I do about 6 to 9 months, somewhere in there.
Yeah, I do 6 months. I mean, most of these men have been fairly worked up pre-BPH surgery, and you have a pretty high confidence that you're not missing cancer. You've done an MRI, you've done serial PSA. So there isn't necessarily a rush to do a PSA. You don't want to get a falsely elevated return. So I think 6 months is very reasonable at the earliest.
Right. All right. And then I think we'll go next slide. All right. And Wayne, you already alluded to this. I mean, I think this slide really highlights the fact that we can't forget the bladder, right? And I think, Wayne, this is your big message here. The idea of addressing the bladder at the same time of addressing the prostate. And I think it really it really highlights the fact that we really have to be very patient-centric and really think about how to address these symptoms. So, Dean, Wayne, how do you incorporate this into your practices?
I think if you're able to determine that someone really does have overactive bladder, especially if they have detrusor overactivity and urodynamics, you know it's going to take time for the storage LUTs to improve. It can take up to a year after BPO surgery for OAB symptoms to improve. So the argument with this is give them Botox at the time of disobstructing surgery to reduce those storage symptoms, to reduce the risk of urgency incontinence, because once you open up the prostate, all of that detrusor instability may actually result in leakage. And so you kind of just want to bridge them over those first 6 months with Botox, and then maybe they won't even need it in the future. It really is about quality of life.
Absolutely. And I think that he highlighted that often for those guys with bad urge incontinence, that these are good candidates for the intra-operative Botox. And I think that it's also just helping manage our patients' expectations, helping them understand, hey, Mr. Smith, you've actually got 2 problems. Problem 1 is that prostate's getting tighter as it gets bigger. Problem number 1 impacts and creates problem number 2, which is your bladder muscle that's not transplantable is now struggling. And so when we deobstruct you, we're only taking care of problem number 1. Option 1 is you can let problem number 2 heal by the tincture of time. But during that period of time, it can take 6, 9, 12 months. But in the meantime, we can help manage with beta-3 agonists or with Botox at the time of the procedure to help alleviate and mitigate some of those symptoms that can be persistent and initially get worse before they get better.
All right. So we'll go next slide. All right. I thought this was another great presentation with Dr. Patel about medical legal pitfalls. And I think it's great to incorporate that in because, I mean, it's an important part of our practices. I thought the idea of talking about complications and, telling the patient what happened and what things are known, what things are unknown. I think a lot of times when things happen that we don't want to hear or see, we tend to run away from it, but I think we have to embrace that. And I think there's a degree of uncertainty to the things that we're doing, especially when you get into very novel procedures. And it's include the patient in the plan. What did you guys think of this, and how do you incorporate this in your practices?
Well, number one, I think this is a really valuable learning point for everyone who practices medicine and surgery. And number two, I really liked it just in terms of the overall program of the SOBPD, is that we are able to bring in these sort of out of the box, non-traditional talks to our members. And I think that's why it's really a great society meeting. Because
And I would say also things we don't talk about, things we almost like we're sheltered. We try not to talk about it. So I think I agree. It's a great way to highlight it.
Yeah, I agree.
I think just two quick takeaways for the community urologist. This talk was fantastic. The presenter talked with a malpractice lawyer. Two takeaways. One is make sure you talk about persistent irritative system post-operatively. And the second, which I thought was interesting, if you're performing a MIST, here it says must document prostate size. So I guess there must be some history where maybe the wrong MIST was used for the wrong size. So just something to know about, because we're here to protect you as defenders of the detruser.
Great. So we have a couple of questions coming in, and for the last about 15 minutes that we have left, I would like to open up the floor and ask a couple of questions that have been coming. So we discussed a lot about different elements that were key from SOBPD. Dr. Chughtai, just to wrap it up, what would you say are the top 3 take-home messages from this year's annual meeting, and how they could be implemented within the practices?
Yeah, so I would say one of the top key messages, I think one is, the day before the meeting, we actually had a wonderful resident session, and we actually had a lot of technologies. So I think the area of male LUTs, specifically BPH, is really growing. And I think there's definitely a need for men, and they're very interested in these multitude of therapies that are available to them. And I think the excitement among the urology community as well as for patients is great for all of us.
Great.
Anything you want to add, Dean or Wayne, for that one?
I think we spent a good amount of time really talking about that interplay between bladder health and BPH. There were talks from Wayne. They were looking at different diagnostic studies, looking at OAB in men, thinking about the new technologies coming out, whether they disobstruct and how they work. I gave a talk on the next generation of stents that are going to be coming out, sort of first-line interventional therapy, or FIT. And I think this is a real interesting, novel area where we're going to be able to treat BPH earlier with these small, minimally invasive devices as an alternative to medical therapy. I think that's quite exciting.
I also want to ask a follow-up question. Were there any surprises in terms of things that didn't make it this year in the discussion that you thought would be more prevalent as years come, or you were surprised that they weren't part of the discussion this year?
I mean, Wayne, do you want to take that one? Any surprises for you?
I mean, I'm biased. I want more on urodynamics, understanding bladder health, diagnostics. How do we integrate? As you guys know, I have this thing, basic, enhanced, and advanced urodynamics. I want to have a conversation about how well does cystoscopy with trabeculation, cellulose diet predict bladder outlet obstruction, right? How do we look at IPPs greater than 10 millimeters? So understanding anything that can shed light on bladder health, whether it's basic, enhanced, or advanced urodynamics. And, I think we're seeing a lot about understanding the de-obstructing technologies, but yes, once again, the diagnostic technologies. And I think the future, right, on one of my slides, I had, 3D ultrasound or imaging, spinning the bladder and the prostate to understand what's the best fit, whether it's a FIT or a T-MIST or a MIST or so forth. I think that's going to be exciting for us to anticipate for the future.
Yeah, I would tell you, I think what's amazing about it is, I think Dean, you already said it, there's a lot we don't know. And there's a lot of and as we're learning more and as we see new technologies, there's new things that come up, like measuring bladder angle, prostate urethral angle. How do you do it in a reliable way? We all know when we see a really high bladder neck, but how do you define that? And I think there's a lot of unknowns here.
And talking about diagnostics and that it needs a lot of historical data points, what do you think are some of the things that ordinary consumers or like anybody who's concerned about their prostate or their health consumers, even before they come to see you guys, what do you think will be some of the tools or methods possible to take care of, like for better shared decision making and better patient engagement? What would be some of the tools that you recommend or some guidelines that you give?
Yeah, I would say that right now there's a lot of good questions. Like we don't know the timing of procedures, and in a lot of ways we're using the patient's bother to dictate what we're going to do and when we're going to do it, right? And the timing of procedures is a challenge, and we don't have great data on when to do these things. I think we alluded to the idea of like these home-based tests, proudP obviously being one of them. And does that allow us to diagnose earlier, or at least define a norm for men? Wayne, Dean, do you guys have patients do some type of home-based test prior to their first visit?
I haven't currently before the first, just logistically in my operations, but it's so important, right? I think what really needs to start at a community level, at a government level around the world is just talking to men about bladder health, right? Whether it's bladder health screening, starting at pick an age, 50, for example, men know about colonoscopies and so forth. So understanding, just getting that dialogue, hey, it's not transplantable. It's important to take care of. You're having symptoms, just like if you're having chest pain, that's your heart having problems. If you're having urgency frequency getting up in the middle of the night, it could be your bladder having a problem. So get some data, talk to a primary care doc, and start layering on data. And men are very good, right, with their watches, their smart watches, their phones. Now we have remote diagnostics, whether it's proudP or so forth. But yeah, I think combination of the right dialogue with the right data to now drive deobstruction when warranted.
I think a lot of men aren't necessarily attuned to their bodies, or they ignore some of the symptoms. And that's why we see men presenting with later stage disease compared to women, whether it's the bladder or the heart or you name it. So, a number of years ago, a lot of the newer interventions were all about just like, take the questionnaire. You'd be watching the Super Bowl commercial, be like, take the questionnaire, whether it was for whatever BPH device. And it was sort of like a simplified IPSS. And it kind of just got them thinking like, oh, maybe I do have symptoms. Maybe I should take this questionnaire. And it's like, do you wake up at night to pee? Is your flow slow? And something as simple as that could be the ignition to get men engaged. And they're like, if you score 4 or higher, you should talk to your doctor. So I think these sort of ways to reach out to men are great. Of course, there's going to be really savvy men who will download apps, right? They'll download a digital voiding diary. They'll come across something they can do at home to measure urinary flow. So there's that subgroup of men. But I think just getting them engaged with like asking the question, do I have a problem, is really the first step.
Yeah. I mean, unfortunately, I think a lot of men probably treat their bodies the way they treat their cars, right? A light goes on, you kind of say, I hope that goes away, right? All of a sudden, something fails. Now it's time to see somebody. And at that point, did we get irreversible bladder changes, right? I also think, what's the role of the partner, right? Maybe if a patient doesn't realize they're having urgency frequency, but does their partner recognize it? And is that the way that could be identifying these patients early on as well?
Right. We're getting a lot of analogies today from the car and the bladder talking, and Dean's giving us a whole list of analogies that we can take away from. One of the questions that proudP gets a lot on our side is from the patient side. They're always wondering about how painful the procedures are. And as physicians, how do you explain and guide your patients through this question? Like how difficult it is, or like how painful it is? What are some of the advices that you would give our fellow community about how to guide through this?
Yeah. Dean, do you want to, since you were the first one to unmute, you want to take this one?
Well, I think, first of all, a lot of patients, a lot of men have concerns or fears about procedures. And we've done patient preference studies. We've done actually a lot of research, Bilal and I, looking at what are men concerned about. They're concerned about becoming incontinent. They're concerned about becoming impotent. They're concerned about having pain. And if you can really talk to men and understand what are their concerns and then address them. So I think, fortunately, most of our BPH procedures are not that painful, right? It's very rare that we would ever send home someone on very heavy pain medications. Yes, it's uncomfortable. Yes, they'll have dysuria. Catheters are never fun. But fortunately, with the evolution of technologies and techniques, we don't see a lot of incontinence. We don't see a lot of pain. And we can talk through men what to expect in the usual course of healing. And so I think that's just really helpful. Is not that is it going to be painful. It's more to prepare them about what to expect, what is normal, and then most men will be totally fine as they go through the steps of healing and recovery.
Agreed. And I would say, like, Dean and Wayne, I mean, I think one of the things we learned from like the Learn questionnaire is the fact that some of these men present with preoperative pain, right? So I think when it talks about like the overall procedure, I think it's important to talk about like Dean described in the context of the whole disease. Wayne, how do you counsel your patients?
Yeah, just to kind of add to what Dean said there, when we talk about preferences and values of patients, what we're starting to see, and I think there's several academic places starting to look at, when you look at if you share the 5 stages of bladder health, how does that prioritize the preservation of bladder health versus having a catheter or postoperative discomfort? That with the fear of getting to stage 3, 4, and 5, men are going to be willing to put up with a little bit more because they know they're saving their non-transplantable bladder. I think also that at this time, I think when I work with guys, it's really about just making sure they understand their expectations. And one thing is, give me 6 days, whether it's a list or a mist or a small office procedure, because I can tell you, Mr. Smith, with your IPSS of 22, you can't live like this for the next 20 years. You have to do something. And, for that reward, we have to take on a little bit of risk and a little bit of discomfort. And this is what we can expect, but knowing that it's temporary, but the benefit for you and your bladder is tremendous and it is worth it.
Okay, great. And I think we can cover the last question. So as a one-liner, one sentence, what would be any practical tip or pearls from this meeting that you recommend to colleagues? One thing for each one of you.
I think I'll go. Number one is you got to start with getting the diagnosis right. Mm-hmm. That is number one. You need to understand what is going on. Is it OAB? Is it BPH? Is it a mix? Is it nocturnal polyuria? And along with that, as you get into coming up to a treatment, you got to gather data, as Wayne has really well pointed out.
Great. Dr.
Yeah, I mean, sorry, Wayne, were you about to go ahead? But I was going to say, I definitely would echo Dean's comment. I think we did see presentations on, male overactive bladder, and that is how a lot of men can present. And I think as a community, we do have to recognize that there's a multitude of conditions that can cause urinary tract symptoms. But if you're working off the incorrect diagnosis, or if the patient's working off the incorrect diagnosis, it can be very hard to move these patients forward.
Absolutely. I think in the modern man, we're putting on that armor of masculinity to lower their defenses and have them take off that armor. We need data. We need the right dialogue. We need to explain it. Yeah, your bladder health is at risk here, but good news. We live in this golden era, as Dean talks about, golden era of BPH and BPO diagnostics and therapeutics. We have options to help you become the best version of yourself, to be the best father, husband, coworker, boss, right? And I think we want you, Mr. Smith, to have the best version of your life, chemical-free and catheter-free.
Okay.
And I think another point that I also want to highlight, like, I think the meeting really did show how we have a multitude of therapies, but nothing is perfect, and it really is mixing the right therapy for the right patient. And I think that's a very important part of it too. And as Wayne said, at the right time.
All right. Okay. Thank you so much. Okay, so this will be a wrap for today. I want to extend a heartfelt thank you to all three of you, Dr. Chughtai, Dr. Kuang, and Dr. Altman, for being here today and for sharing your expertise and your takeaways from the meeting. It's exciting to be part of this evolving landscape. And if you'd like to learn more about Soundable Health and our ongoing initiatives, please visit our website at proudP.com. And we have also prepared a special demo promo code, a 15% discount for those that have participated. And this is to share for your parents. I would like to wrap it up saying thank you so much. And Soundable will be hosting these very insightful webinars from now on. And next event will be with Dr. Jerry Plybus on remote uroflow monitoring and unraveling the secrets of its untapped diagnostic potential. So until then, take care. We'll see you all in March. Thank you so much, all three of you. Thank you.
Thank you, Minsu.
Thank you, Wayne.
Awesome job.
Thank you, Minsu.
Thank
Hey,
you.
Bilal, thanks.